Welcome dear students, I am Dr. Pratyusha and in this video, let us learn about one of the most important complications of chronic otitis media and that is meningitis. Let us see how otitis media results in meningitis and what are the clinical features and management of meningitis that occurs as a result of otitis media. So first, what is meningitis? It is the inflammation of leptomeninges. As you all know, there are three meninges, dura mater, arachnoid mater and pia mater. But the dura mater is never involved in meningitis. It is only the arachnoid and the pia mater that get involved in inflammation. So, meningitis is the inflammation of leptomeninges, that is pia and arachnoid mater, usually with some bacteria. Plus, there is invasion of these infective organisms into the cerebrospinal fluid also. That is meningitis. So, meningitis is inflammation of leptomeninges with pyogenic bacteria. Along with invasion of the cerebrospinal fluid. Meningitis is the most common intracranial complication of otitis media, and this can occur as a complication of both acute otitis media as well as chronic otitis media. In children, it usually follows acute otitis media, whereas in adults, it is mostly a complication of chronic otitis media. Now, let us look into the causes of meningitis because of otitis media. Now, every middle ear infection does not result in meningitis. What are the predisposing factors? Let us see. Now, meningitis could be caused by, as we have just discussed, suppurative form of otitis media, whether it is acute or chronic. It can also occur in a temporal bone fracture. When there is temporal bone fracture, there is direct communication that could result in infection of meninges. CSF leak is another possibility. And finally, even a middle ear or a mastoid surgery can result in meningitis. Middle ear or mastoid surgery. Now, what is the pathway of infection? How is this infection reaching the meninges from the middle ear? That is important. There are a few natural and normal pathways and also sometimes certain abnormal pathways of communication are present. Let us see all of them. Now, the middle ear and the mastoid infection reaches meninges sometimes by some pre-existing pathways, pre-formed pathways, such as a patent petrosquamous suture, patent petrosquamous suture, from the perineural spaces of the internal auditory canal. Internal auditory canal connects the inner ear to the brain and perineural spaces in the internal auditory canal can act as a pathway for the spread of infection. Another route is blood-borne infections. Chronic infections can spread via hematogenous pathway. They spread by bone erosion followed by retrograde thrombophlebitis. Hematogenous route is another pathway which could also involve retrograde thrombophlebitis. Retrograde venous thrombophlebitis could be associated with extradural abscess or granulation tissue formation. And sometimes we observe that there is a direct erosion of bone that can occur after mastoiditis and petrositis, and even dural erosion could be possible. Erosion of bone. This acts as another pathway. So all in all, these three pathways are usually possible that could lead to meningitis from middle ear. Now let us look into some of the common microorganisms that are usually responsible for meningitis following otitis media. First among them is Haemophilus influenza and also Streptococcus pneumoniae. These two organisms are usually responsible for meningitis. Apart from that, even certain anaerobic organisms can also cause meningitis. Very rarely it could be a polymicrobial infection, and if it's a polymicrobial infection, it is slightly resistant for treatment. Next, if we look at the clinical features of meningitis, all the symptoms seen in the patient are usually because of the presence of infection and also because of the raised intracranial tension that occurs because of infection of the meninges. Plus, there is meningeal and cerebral irritation that is responsible for certain features. These are the three common reasons responsible for whatever clinical features the patient is experiencing. Now, the first and the earliest feature that is usually found is fever. Because it is an infective condition, fever is usually present, and a fever in the range of 102 to 104 degrees Fahrenheit is observed. This is generally the first symptom experienced by the patient, and this fever is usually accompanied by chills and rigors. Because of the meningeal and cerebral irritation, headache is also experienced by the patient. Then there could be vomitings. For the same reason, because of meningeal irritation, and this vomiting could sometimes be projectile vomitings. That is, it is not preceded by a nausea. Then photophobia is experienced by some patients, along with irritability and restlessness. These are a few general and early symptoms. Now looking into more specific symptoms of meningitis, we have seizures. Seizures could be present in infants and small children. Neck rigidity. Now neck rigidity is a very important sign of meningitis. Then we have something called as Kernick's sign. What is Kernick's sign? In a patient of meningitis, when we are examining the patient, extension of the leg with flexion of the hip will cause pain to the patient. Normally, let me show you a picture. As you can see in this picture, the patient's hip is flexed, and now when we are trying to extend the knee is flexed in this picture, and the examiner is trying to extend the knee. This will cause pain to the patient. This is Kernick's sign, which is classically seen in meningitis. It's a simple bedside test that can be performed, and that should arise a suspicion of meningitis. Just like Kernick's sign, there is another test called as Brudzinski's test. It is Brudzinski's sign. Let us see what is Brudzinski's sign. In Brudzinski's sign, flexion of the neck will result in flexion of the hips and knees. Here, as you can see, the examiner is trying to flex the neck of the patient, and this is automatically causing a flexion of the hip as well as the knee. This is called as Brudzinski's sign, and if Brudzinski's sign is positive, it is indicative of meningitis. So, some specific signs that we have seen are seizures, neck rigidity, Kernick's sign and Brudzinski's sign. Along with these, it's also possible that the patient could have motor deficit. What do I mean by motor deficit? There is either cranial nerve palsy or hemiplegia. Anything is possible. Cranial nerve palsies and or hemiplegia. Next, the deep tendon reflexes. Deep tendon reflexes are initially exaggerated, but later they become sluggish. And in later stages, we find papilledema in the eyes of the patient. Papilledema is seen, and finally the patient may go into a stage of delirium. Delirium and coma also. Initially the patient is drowsy and he may progress to delirium and coma. So a complete examination of the nervous system is done, and these are some of the classical signs and symptoms of meningitis. Now let us look into the diagnosis of this condition. The first and foremost thing to be done is imaging. A high resolution CT scan has to be done. This is the imaging modality of choice. Now this provides us the bony details, plus also it rules out some congenital abnormal pathways that could be present in the patient, such as a CSF leak or some abnormal communications between the ear and the brain, that is leading to spread of infection. After CT, we can also get an MRI done. An MRI will show middle ear pathology also. If there is any infection and fluid that is present in the middle ear, it can be seen via an MRI. A fundoscopy can be done to visualize the papilledema changes in the eye. And most important part in diagnosis is a lumbar puncture. Now I told you infection of the meninges usually invades the cerebrospinal fluid also. So when we do a lumbar puncture, we can collect the cerebrospinal fluid and send it for both histopathological as well as microbiological examination that will give us a clue about the type of inflammation and infection. So CSF examination will show many features such as CSF examination reveals the following information to us. First, we can observe the nature of fluid. Nature of fluid, that is, whether it is turbid, blood-stained, serous, purulent, all these things can be observed just by mere physical examination. And then we can also look about the cell count. If there is predominance of neutrophils, it indicates a bacterial infection. If you find more of lymphocytes, it could be a viral etiology. All in all, a complete cell count can be analyzed. Usually in infective conditions, what we find is a decreased glucose percentage and an increased protein content. This is found. Next, a gram staining of the fluid can be done that will help us identify organisms. This is followed by culture and sensitivity to exactly find out the causative organism and also see to which antibiotics it is susceptible. Apart from this, now because this entire condition is occurring due to middle ear infection, we have to also collect the middle ear fluid. Pus or any secretion from the middle ear is collected and sent for examination. Culture and sensitivity is done and also that fluid is examined. Culture and sensitivity will give us the causative organism with its antibiotic susceptibility. After these diagnostic procedures, now let us move on to treatment of this condition. First and most important part of treatment is antibiotic therapy. Initially, empirical therapy is given. Later on, based on the culture and sensitivity reports, we either shift the antibiotics or continue with the same antibiotic. Third generation cephalosporins or penicillin or ampicillin are usually used. We give them by intravenous route for a period of 7 to 10 days. Okay. After antibiotics, next important part is corticosteroids. This will help to reduce the neurological complications associated with meningitis. Now sometimes in spite of giving medical therapy, the infection does not subside. This is because of an aggravated middle ear condition such as there is uncontrollable mastoiditis or Cholesteatoma is present in the middle ear that requires a surgery. In all these conditions, we go for surgical management. Surgical management of the middle ear pathology that will automatically address the meningitis issue. Usually the surgery that is performed is mastoidectomy. Either a radical or modified radical mastoidectomy is done because that is the root problem. Now surgically the condition has to anyhow be addressed. Generally what we do is after giving medical therapy and the patient is in a stable condition, then we go for surgical management. But sometimes if medical management is not giving satisfactory results, then we have to go for surgery immediately. So this is about meningitis, which occurs as a complication of otitis media. So we have to remember about the causative organisms, the pathways of infection and the clinical features of meningitis, most important of which are neck rigidity, projectile vomitings, Kernick sign and Brudzinski's sign. Along with that, diagnosis most importantly comprises of imaging with a CT or an MRI along with examination of CSF fluid that is obtained by a lumbar puncture. And treatment is by antibiotic therapy and surgical management of the middle ear condition that has led to meningitis. So thank you very much.